Hello, and welcome to the second part of our coverage from EHA 2026. In the first part, we looked at the topics of high-risk smoldering myeloma and initial first-line treatment options. In the second part of our discussion, we want to examine the various options that are in the pipeline for relapse cases, especially bispecific antibodies and CAR T-cell therapies. As mentioned, there is a lot happening in this area as well, and I am pleased that Professor Scheid will give us an appropriate insight into this.
Yes, indeed. Thank you very much for the wonderful opportunity to delve into and discuss relapse therapies as presented at the EHA. I would like to start with one of the major highlights. Already at ASH in December, the first 4 patients were presented who in Australia were treated with a CAR T that is actually generated within the patient, where you don't collect cells beforehand and modify them in the lab, but rather the vector is essentially injected directly into the patient, meaning the gene probe is injected and then the CAR T cells develop within the patient. So a fascinatingly simple concept. And now at the EHA, more patients were presented, 18 in total. These were patients who had already undergone significant prior treatment with at least 3 previous therapies. Their primary goal was to conduct a thorough study to ultimately determine how truly effective and successful this specific type of medical treatment would be. Vector, which causes the cells to develop within the patient while avoiding all the logistical steps like cell collection, apheresis, and shipping to large laboratories, return transport, and freezing. It helps to avoid all of that. Strikingly simple. It took a median of 13 days from consenting to participate in the study to the injection of the vector. So this is really very, very quickly implementable. Various dosages were used, tested with the vector. It was observed that the vector works well. Therefore, they started the process of gradually lowering the dosage in order to ensure that more patients could be treated with the same amount of vector. And of course, the primary endpoints were to carefully assess efficacy, safety, and side effects. And we also need to see whether the vector is genuinely and effectively capable within the patient to generate CAR T cells in a clinically significant and relevant quantity. And to provide clear evidence to demonstrate this point, we can see these cells are generated very well. All the way to the left, the curve in the blood shows how after 11 to 12 days, the CAR T cells in the blood suddenly become measurable in a relevant number and to some extent also persist over time. We see no real differences between the various dose levels. So this vector seems to work very well, and we can't directly correlate the amount of CAR T cells with the injected vector. And as shown on the right in the graphic, you can also see that such CAR T cells are detectable in the bone marrow as well. And now the dose is being continuously reduced further and further to see how low we can go with the dose, to find out what the minimum threshold dose is that still allows for the generation of relevant regarding these CAR T cells. The efficacy data available are still in the early stages. We still have a limited amount of follow-up time for these patients. In the top bars, we see about 1 year of follow-up. You can see how the remission deepens over time, how the proteins gradually disappear from the blood, and that the patients are in a stable and sustained response. Of course, the lower dose levels have only been under observation for about a quarter of a year. But for now, you can definitely see a response. We see an overall response rate of 100%, which we have now come to expect with CAR T cells. And for the patients who have been in follow-up for at least 4 months, we also see a very deep response. MRD negative response shown at the top right in 100% of the 14 patients who were biopsied. And at the bottom right, once again, the drop in soluble BCMA under free light chains. So all of these are data that clearly demonstrate to us these cells, which grow and develop in the patient, they also expand, they proliferate, and they clear out the myeloma cells just as efficiently as we are used to from the autologous CAR T cells, which we use routinely. This is somewhat like cilta-cel, which we have available right here in Germany. But we also see the typical side effects of CAR T cells. 2/3 of the patients developed a cytokine release syndrome. It was grade 1 or 2 in all cases. As we know with BCMA CARs, they usually only cause a mild cytokine release syndrome, never grade 3. Infusion reactions occurred when the vector was injected. They started using dexamethasone as a prophylaxis. This immediately limited these infusion reactions. Cytopenias were certainly noticeable, but very limited, very few, none at all, especially no grade 3 cytopenias after day 28. Certainly a factor, since no chemotherapy was used here. In addition to omitting apheresis and all the cell logistics, they also skipped the 3 days of chemotherapy. For people like us who are experienced with chemotherapy, it doesn't really seem to be a big issue, but we do notice that it definitely contributes to cytopenia after CAR T-cell administration. And if you leave it out and are able to leave it out, it makes the therapy significantly more relaxed, at least in terms of cytopenias, which are already a very relevant side effect for some patients. So very impressive data with 18 patients. Even though the T cells in the patients were very different in terms of their distribution, so you could definitely expect that this vector might not harmonize well with all cells. All patients here very reproducibly generated the CAR T cells. We saw a 100% MRI negative response. We did not observe any severe side effects, no severe cytopenias, very few neurological side effects. So overall, a very tolerable profile for these in vivo CAR T cells. And of course, the process of supplying clinics with a vector is every bit as straightforward and simple as it is with antibodies or other medications that we regularly obtain from the pharmacies. That would, of course, immediately shift this entire logistical challenge to a perfectly standard and ordinary concept where a pharmaceutical company is responsible for manufacturing something, keeps it in stock, delivers it, and we can obtain it from the pharmacies. That would significantly improve the availability of CAR T cells if it were to be approved. So what is the conclusion? Of course, none of this is approved yet. There's still a long way to go. But for now, it's truly revolutionary. To even consider CAR T cells without apheresis, without transport, without waiting time, without LD chemotherapy. So far, with limited patient numbers, we are seeing very good efficacy and tolerability, but long-term data are lacking, and that will be the major challenge. We actually want to see comparative data and be able to say, should I use in vivo CAR T cells or an existing CAR T cell like cilta-cel, for example? And then after 2, 3, or 4 years, I look at what the side effect rate is and how remission is maintained with these two approaches. Only then can we really make a judgment. And of course, these are precisely the kinds of studies that are very expensive, very complex, and that companies usually try to avoid. But we will see what the future brings and how things develop. These concepts are currently also being tested in the USA. So Australia and the USA are currently active in this area. And we will see how things continue to develop in the studies. Now, large pharmaceutical companies have jumped on board to push this concept forward. We will watch for further updates from one congress to the next as information becomes available. Another way to move away from this very complex cell logistics, where I collect patient-specific cells and manufacture CAR T cells from them, would be if I simply take T cells from healthy donors and use them as allogeneic CAR T cells that I can then offer. We are already familiar with cell therapies, including approved cell therapies in other fields, where we can ultimately obtain such cells from companies, which are then delivered frozen. And within a few days, I have the cells here at the center and can administer them. That would be an example of an allogeneic BCMA CAR T cell therapy. This specific research was presented right here in this specific study. These cells undergo a series of genetic modifications multiple times systematically, because I naturally also have to meticulously prevent any potential adverse immune reactions of the donor cells against the patient's body. Consequently, at least 4 distinct and essential genetic modifications have to be carefully made to the donor cells here to ensure the procedure is successful. Not only is the BCMA cloned into the cell as a receptor, but the existing T cell receptors also have to be silenced. Patients included in this study had received at least 3 prior lines of therapy, as we know it from various immunotherapy concepts, and then increasing doses of these allogeneic CAR T cells were chosen, and 2 dosages were tested for the lymphodepleting chemotherapy regimen. I will get to exactly why that might be highly relevant in just a moment. The primary objective and endpoint of this study is the safety and the correct dose finding of these allogeneic CAR T cells. Then you look closely at the overall response rate and the specific cell expansion within the patient. First, at the tested or optimal dose level, a very good and promising clinical response was observed, as we know it from CAR T cells. Almost all patients achieved an overall response, over 80% complete remissions, and 91% MRD negative remissions. So first of all, you can say that at first glance, this is on a similar level to the well-known CAR T cells, meaning a high remission rate and deep responses. And here, with about 18 months of follow-up, we observed a consistently stable clinical response among the patients. Only one specific case of disease progression was documented during this period. Otherwise, the overall situation was characterized by a generally favorable and stable response. The tolerability profile was also found to be consistently good for those involved. As we can see in the data presented here, infections grade 3, 17% in patients who had not been pre-treated with BCMA. Perhaps somewhat more infections. Of course, these are all numbers that are still very, very small, which can't really provide us with definitive guidance yet, but are of course interesting to see how things look for patients who have already had CAR T cells or BCMA therapies compared to those who have not yet had them. CRS was rare. Only a third of patients developed CRS at all. That is remarkably low, and there were practically no severe cases of CRS. ICANS were also rare. Only 3 patients developed it here. So overall, it could be argued that it has a rather more advantageous safety profile when measured against the known autologous CAR T cells. GVHD, that would also be relevant if these donor cells were to react against the patients. That would result in GVHD, graft versus host disease. That was not observed at all. But, and this is also relevant, prolonged, that is, persistent cytopenias occurred in about a third of the patients. Of course, that's something we really don't like to see when the patients are responding remarkably well, but then they might actually even need transfusions because the bone marrow is somehow weakened and not producing enough cells. Here there is clearly a relevant problem signal, namely that the cytopenias need to be taken into account. The second thing I found very remarkable was shown here on the left side. There were patients who responded well and who also showed a nice expansion of CAR T cells in their blood. We also see here the typical time profile. After about 10 days, the CAR T cells in the blood visibly increase. They proliferate vigorously and do their job, as I always say. And after about 4 to 5 weeks, they drop off significantly and enter a kind of resting state. We know this very well when we administer CAR T cells in routine treatment and see exactly these kinds of curves with cilta-cel. But this was only the case in 18 patients here. And then we see 2 curves below, patients with a partial remission or no remission at all. In other words, those who did not respond, they also showed no expansion whatsoever. So here there were patients whom I wouldn't consider non-responders, but rather non-expanders, meaning patients who somehow, whose cells did not manage to grow into a relevant population within the patient. And then, surprise, surprise, I also don't have a real response. That's what the computer showed. The decline of the free light chains. We've also published on that. We can look at the light chains after 4 weeks and say, if there is still something measurable in terms of light chains with the current CAR T cells that we have, then a true response simply hasn't been achieved. Then we also have a very short progression-free survival. The patients quickly experience tumor activity again. You can see the same thing here. Where the CAR T cells did not expand, we have virtually no significant reduction in tumor burden. And you can also see there, it already starts to rise again a bit by day 30. So there is a problem in a portion of the patients, about half you could say here, where the cells somehow don't accelerate, don't ignite, don't proliferate, and therefore, of course, don't have any effect. On the other hand, this is, of course, a very exciting option. If patients have already received CAR T cell therapy, then hopefully enjoyed several years in remission and have felt well, and then show another increase in their light chains, show a relapse, then you want to be able to offer them something. And here, shown in a case example, they administered these allogeneic CAR T cells and saw that in this case, the expansion was very good around day 20. You can see in the same time window, this rapid drop in the free light chains as well. And in parallel, the CAR T cells decrease again once the goal has essentially been achieved and the BCMA positive cells are no longer present. Then the stimulus is gone and the cells no longer proliferate. So definitely an exciting alternative for patients after CAR T cell treatment. Of course, so far only available in studies, not approved yet. But in any case, it is clear that GVHD does not play a role in this situation when you modify these CAR T cells through 4 gene edits that silence the T cell receptors. There were few other relevant side effects here. One case of Guillain-Barré syndrome, so neurology also plays a role. There are neurological side effects, but they are rare. Otherwise, the efficacy is on the level of the existing CAR T cells, with a rather more favorable side effect profile with lower rates of cytokine release syndrome. And we see that this dose expansion is very clearly observable in the data, but you will almost certainly going to require this higher dose of chemotherapy beforehand. Apparently, the cells need a significantly higher level of support to engraft successfully within the patient. And therefore, as a conclusion, I think this immediate availability is already very attractive for patients with urgent treatment needs. It makes things logistically much easier for manufacturers in the pharmaceutical industry, but also for the centers that have to receive and store these cells here. I see the good safety profile, but the cytopenia, especially with the higher dose of chemotherapy beforehand, is still a problem. We need to take a closer look at that. We see good efficacy with and without prior exposure to BCMA-targeted therapies. And I definitely see a need for further optimization to achieve safe expansion in all patients. So we are only at the beginning of the learning curve. And of course, the question arises, if I have CAR T cells targeting BCMA, what do I do if the patients have become BCMA negative? That can certainly happen after CAR T cell therapy, and it happens more frequently after bispecific antibodies. So we urgently need CAR T cells that target other antigens as well. Are targeted, and here is an example. Arlo-captagene autoleucel is directed against GPRC5D, which is exactly the same target molecule as talquetamab. So this is a well-established, proven target in myeloma therapy. We know for sure that it works. So it is, of course, obvious to develop a CAR T cell against it. And that is exactly what is being done here. The study in which this Arlo-cel was tested in a phase 1 study, these were patients after 1 to 3 prior therapies. As known from other studies, it follows the same principle. Patients who typically received prior CD38 therapy. And then it was rigorously evaluated whether this single administration of the specifically determined dosage level was both clinically effective and fundamentally safe. It was able to be manufactured in 100% of cases. That is an important piece of information, that there are no issues in the manufacturing process that would prevent the product from being produced optimally. The dose, as mentioned, about 60% received a bridging therapy, and we have 18 months of follow-up. So here too, the data are still immature, but they may already provide an initial indication. The primary focus is on tolerability and safety, but of course also on response and deep response, and on pharmacokinetics. How was the tolerability? So, of course, with these kinds of CAR T cell therapies, just due to bone marrow suppression caused by the chemotherapy, we see relevant side effects. We see cytokine release syndrome in over 80% of cases, as we do with many CAR T cells, but all were grade 1 or 2, so a mild cytokine release syndrome. ICANS occurred in only 3 cases, just under 10%. Otherwise, no relevant side effects. Very few neurological side effects. This mainly involved dizziness, unsteady gait, as we are also quite familiar with from talquetamab. Here, GPRC5D is apparently somehow relevant, because this appears to be very comparable between the CAR T cells and the antibodies against GPRC5D. And of course, as you can see, here abbreviated as OT, on target of tumor, meaning related to target molecules, but not on the tumor cells, rather on other cells. Here we're thinking of skin cells, mucosal cells, which can also express GPRC5D and therefore can cause side effects. We see that about half of the patients also experience such effects. So the CAR T cell activates very similar mechanisms there, just as we have already seen from the side effects of talquetamab. So here, the same target organs, skin, oral cavity, nails, as well as taste disturbances, weight loss, so all the things we know from talquetamab. But here we see the big advantage of a single administration. This target molecule is activated and set into motion once it reaches both the skin and nail cells, and then no more. If you take a look right here at the data, you can see that we are observing clinical events in anywhere from 25% to 40% of the patients in this cohort. At first glance, that seems to be less than with talquetamab in terms of frequency. And you can see that it also resolves quickly. Quickly, in quotation marks, 50 to 100 days is still quite some time. That's something you have to accept as well. But I can largely rely on the fact that with a high probability, without further intervention, this effect will gradually disappear after a period of up to 3 months. And because I'm not receiving a new substance again and again, but rather this CAR T cell is administered just once. Otherwise, response rates are at the level we know from CAR T cells, so almost 100% response, over 70% complete remissions. And as shown at the top right, over a period of about 2 years, we do indeed see a stable response in most patients, which is also to be expected when most patients have become MRD negative. So you can say efficacy is on par with other CAR T cells as well. So GPRC5D as a target works with CAR T cells. Progression-free survival rates. Yes, you have to take a look. You have to see again where the bar is set, how other therapies perform. With an 18-month PFS rate of 72%, I would say a significant degree of caution is certainly warranted. There may still be a clear and present need for further refinement and improvement. Is this response truly stable and reliable enough for this specific group of patients to be able to keep up? The competition is exceptionally intense, and I would still remain quite a bit more skeptical about the ultimate outcome, whether in its current form, this response is sufficient to fully develop this therapy to a truly comparable level, as we see with other therapies. To summarize, we can definitely make good use of these cells because they are easy to produce and they are definitely effective. And in terms of depth of remission, they can keep up with CAR T cells. When it comes to the duration of the response, I would put a small question mark there and see a bit of a need for improvement there. Otherwise, tolerability is certainly very good, especially regarding CRS and ICANS. But of course, other CAR T cells do not have this. With BCMA-targeted CAR T cells, these on-target side effects on the skin, mucous membranes, and nails. Therefore, more than with other CAR T cells against BCMA, less than with the bispecific antibody against GPRC5D. So somewhere right in the middle, and often reversible, since no further therapy is administered. Once they have been included, and regardless of the current situation, there is an ongoing global study with a comparator arm, the Quintessential 2 study. Consequently, we will wait to see how this turns out in patients have had 1 to 3 prior treatments with such a CAR T cell compared to the data we already know regarding BCMA CAR T cells. So to evaluate this again, I believe it would be beneficial if we have CAR T cells that are also designed to target other cellular structures, particularly in cases where BCMA is limited. It might be lost at some point. We have high response rates, and we see fewer infections overall that were observed throughout this clinical study. We did see the common and expected side effects here as well, but it is important to note that they were less frequent and of shorter duration than, for example, with antibodies against GPRC5D. And as mentioned, comparative data are lacking, but of course this will be generated in the phase 3 study, where there will be a comparison between a classic triplet therapy and CAR T cells. So this is another path being pursued, which will provide us with data and may perhaps also lead to the approval of this product for use in early relapse. Yes, of course, you could also say, while you're at it, constructing CAR T cells, why not? Target 2 structures at the same time. So why not develop a CAR T cell that binds both BCMA and GPRC5D? And I also found it absolutely fascinating to gain a deeper insight into the toolbox of CAR T developers, because this was actually extensively showcased at the Congress. How did they go about developing such a dual CAR T cell in the lab and try to optimize it before it went into phase 1 testing? And the ongoing study is using exactly such a concept to actually treat patients with this dual targeting strategy. And of course, patients are supposed to have been pre-treated with all three substance classes, as we know it from quadruplet therapy. But no clinical data was shown here. Here they simply showed, first of all, how they approached the development of these CAR T cells. And of course, you can imagine it. It's really like a modular architecture. So the goal is to effectively combine two binding domains. On the left side, you see the individual receptors which possess a binding site for GPRC5D, as we saw with Arlo-cel. Or on the right, a classic BCMA CAR T, in this case the Arlo-cel, which we do not yet have in the clinic. But then at that point, you can take some time to think about exactly how to put this all together. If I want to have both structures on a single molecule, there are actually a variety of models for this, for how to link them together and how the molecule as a whole then folds so that it can interact with the cell in different ways and bind to the molecules on the cell surface. That's something you don't really realize, how many development steps are actually needed in the lab, because there are just so many possibilities to either make it a straight linear chain or to form a fully closed loop within the molecule. And that's something they actually tried to test in the lab on different cell lines to see, for example, what happens if I have a cell that expresses only a little BCMA and maybe also only a little GPRC5D. So a pretty resistant myeloma cell which has already learned to display fewer molecules on its surface. And you can imagine that perhaps this dual recognition is especially effective in such cases because maybe I only need a few molecules to trigger recognition with such a dual binding strategy, after all. And here it was clearly observed that this linear structural concept was not at all optimal for the binding process, but rather that this specific loop formation was actually much better for the interaction. This is clearly shown on the left side, where the killing of the target cells with these CAR T cells worked significantly better and showed much higher effectiveness. Looking at the graph on the right side, they also examined what happens if I specifically use BCMA CAR T or GPRC5D CAR T, which are represented by the yellow and blue lines. Then in our mouse model, I see a relatively short-lived therapeutic response, followed by regrowth of the myeloma cells. And then you can see these two curves at the bottom in green and purple, that these dual binding criteria were apparently better able to better manage and control those specific cells that express only relatively little BCMA and GPRC5D to control them better. So in the lab, there were indeed numerous excellent opportunities to test out how these various different engineered binding structures perform. These therapies are able to identify and eliminate elusive cells that might be hiding a bit from the CAR T cells, which can only recognize either BCMA or only GPRC5D. So to sum it up, it's a bit like looking into a bag of tricks. But you can see there are an incredible number of possibilities when working with two binding sites to optimize them, to position them differently, and perhaps to better equip yourself with such dual CAR Ts, especially when myeloma cells tend to have such a heterogeneous antigen expression, meaning sometimes they express only one, sometimes only the other, or perhaps have only a few molecules. And of course, the hope is that with such a dual CAR T, you can avoid the development of resistance, or even overcome resistance that has already developed, which may have arisen from previous targeted therapies, because that's a question many patients ask. Those who are now receiving antibodies or CAR T cells, aren't we just making the cells more and more resistant? If a relapse occurs, won't it then become difficult to still achieve success with CAR T cells or antibodies? Then I refer to such concepts that are currently in development, saying that we are already preparing for the future so that in a few years, in the event of a relapse of the disease, we might already be able to offer new concepts again, or at least have studies available for such constructs. This study is also open at our center and is indeed recruiting patients who have experienced a relapse after BCMA CAR T therapy. Of course, you can also do the same with the antibody constructs. Naturally, you can also say, if I can build a CAR T cell that recognizes two structures, then of course I can also construct a trispecific antibody. There are already several of these that are being tested. A presentation on this came from China. They also tried to carry out an optimization here, You could say we are building an antibody that recognizes CD3 on T cells and recognizes BCMA and GPRC5D. So here too, it's a look into the toolbox of the primary building blocks of these antigen mechanisms. And here as well, the idea is that maybe I can further refine and optimize this specific type of molecular construct, such an antibody, in its complex binding mechanisms. And then they looked at it and thought, well, we already have available drugs like teclistamab and talquetamab, which can be combined. This has already been done in studies. It was observed that this is highly effective to administer TEAC and TAL together. It is not yet approved in combination, but based on the data, it looks very promising. The question is, can we do even better if we combine the whole thing? J&J, that is Janssen, already has a trispecific antibody in testing as well, which has essentially resulted from the further development of teclistamab and talquetamab. And so, of course, you can try out quite a lot in the lab to see. First, they evaluated exactly how effective these specific constructs are against various myeloma cell lines. And then they carefully looked at what exactly we are looking for when we consider binding affinities. For instance, should the binding process occur very quickly and then remain extremely stable and essentially irreversible? Or on the other hand, do I actually want a more temporary and transient binding interaction? And then they tried to optimize this construct in such a way that the T cell is bound quickly, as shown on the left in the graphic, but is also released again quickly. The idea is to keep the stimulation of T cells brief and thus prevent the cells from becoming permanently exhausted or from being prevented by binding from attacking new tumor cells. So that's why bind quickly and release quickly was the guiding principle for the CD3 part. And on the right side, where the tumor is recognized, they wanted rapid recognition, but a slow release, so that the tumor cells are firmly bound, and then new T cells can keep attaching right onto them. And then, in effect, the antibody should work optimally as a result. That's the idea. You can see just how many adjustment screws there are here as well, in addition to the construction of the molecule and the arrangement of the binding sites. There's also the binding kinetics, the binding speed, both during the binding phase and during the release phase that can be influenced. So even there's a lot of potential for the designers of such antibody concepts to further optimize. It was subsequently demonstrated through testing in the mouse model that these innovative trispecific antibodies perform exceptionally well. In fact, across various experimental models, they may work even more effectively than the simple combination of individual bispecific antibodies. For this particular stage of the research, the TEC-TAL framework was specifically utilized to evaluate the efficacy of these results. And you can see, especially in the model on the right, that the red curves, which represent the trispecific antibody, may actually be significantly more effective here than the combination therapy of two bispecific antibodies. So this is something we will also see in the clinic. And here again, the comparison to another trispecific antibody. Of course, this is a company that wants to market its construct and is presenting data here that suggest perhaps we are performing even better than another trispecific antibody. But of course, this is still in the test tube or here in the mouse model and should be interpreted with great caution. But just as a clear example to summarize, I think you can see that trispecific antibodies represent a truly fascinating field. This is still at a very early stage of research. But I think, as we've seen in this look into the toolbox, just how many adjustment screws are available and how much can still be modified on these antibodies when you see that the efficacy is not optimal. Of course, clinical data are still missing. The studies are ongoing, but we need to make sure that we see significantly more there. But I think we can already say that alongside CAR T cells, another very large and expansive field is opening up, where a lot can still be optimized. And we also need, and I won't tire of emphasizing this, there are many studies that provide extensive clinical comparisons. And of course, there is also a lot of data on the antibodies that already exist, the bispecific antibodies. Of course, these can be given on their own. They can also be combined. And there was quite a bit discussed about this at the EHA. Here is a study, a large phase 3 study, which is also relevant for approval, where a monotherapy was compared with an antibody against BCMA that also binds CD3 to a classic triplet or doublet regimen pomalidomide, bortezomib, and dexamethasone, or carfilzomib and dexamethasone in the MajesTEC-9 study. And after we saw that we can treat exceptionally well with both TEC and DARA, when patients in relapse were not CD38 refractory, of course, many people said, but we still have many patients who are CD38 refractory. What can we offer them? And this is exactly where the MajesTEC-9 study comes into play. This is now testing teclistamab monotherapy specifically in patients who are CD38 refractory, and truly shows us the endless possibilities compared to a regimen like PVD or KD, which we could otherwise also use in this situation where CD38 antibodies are simply not available to us. A large phase 3 study with a well-known step-up dosing phase, and then ultimately a therapy as maintenance treatment, at first still with closely spaced dosing intervals, and then later on in 4-week cycles, and PVD-KD according to the usual respective regimens. The primary endpoint was progression-free survival. Of course, the depth of remission is also assessed, as well as the other parameters we know from the studies. At first glance here, we see a clearly better overall response rate. 84% against 54% overall response. And especially the significant increase in complete remission, we have 16.8% in the control arm compared to over 65% in the teclistamab arm. So once again, looking at the data, as we already know from previous CAR T cell studies, we see this distinctly superior and more effective impact on tumor control. It takes about a full month for the initial response to be seen. The time to achieve a complete remission is now approximately 3 to 4 months on average, the same in both arms. It takes about half a year until this maximum response depth or complete remission is reached. And we see the duration of response after 18 months. 80% are still responding compared to 40%. So a very, very clear clinical benefit here. And I think this is also very clearly visible in the PFS curve. And this extraordinary and significant improvement in progression-free survival here after a period of 18 months compared to the relatively decent standard results, of course, with PVD-KD. So the control therapy also worked here as we would expect. We often use such regimens as bridging therapy before CAR T cells. In that case, I can certainly expect a response for some time. Here, we see a median of 8.2 months, but of course, that's no comparison to this response, where even after 18 months, the median PFS for these patients has not yet been reached, which is a promising outcome. Additionally, we also see a significant clinical advantage here in overall survival. An increase of about 10 percentage points in survival is, in my opinion, very significant and is also a message to me to use this therapy sooner rather than later and not to try a triplet first, because I might otherwise lose a patient during the course of treatment. And before I can offer them this immunotherapeutic agent in a subsequent line, before I can offer them this agent. Side effects. Of course, neither therapeutic concept is free from side effects. We do see significant hematological side effects, perhaps even somewhat more pronounced with the antibody than with the triplet. And we see cytokine release syndrome in 2/3 of patients. Usually mild, that is grade 1 or 2, as we often see and are familiar with. Diarrhea, cough, erythema at the injection site. These are some of the things we definitely observe here in therapy with the antibody. Hypertension is naturally seen more often with carfilzomib-containing regimens or with dexamethasone. So I think this is a balanced side effect profile, but certainly not a reason not to want to use teclistamab here. And infection is, of course, a recurring theme with modern myeloma therapeutics. Here, it is certainly important to note that at the beginning, with the dose-dense administration of teclistamab weekly, every 2 weeks, patients need to be monitored very closely. I mean, even in the control arm, the infection rate here is remarkable, with severe infections in nearly 1/4 of the patients. But with about 1/3, it's even significantly higher in the teclistamab arm. Here, we really need to keep a close eye on the patients and pay very close attention to infections. Then, as we observe over time, after about half a year, this evens out. I still see relevant infections in both treatment concepts. I still see relevant infections in both treatment concepts. It is also important that we not only look at the efficacy, but also compare the side effects. And here we can clearly say there is an increased infection rate, especially in the first half year, but not down to zero. Rather, there is still a relevant infection rate in the control arm as well. After that, we see a similarly high rate of severe infections in both arms at just under 10%. Such data are extremely relevant for us to learn from. Where do I fundamentally need to pay attention to infections? At what frequency do they occur? And how much more frequently do they occur with an immunotherapy concept? When we compare this approach to a comparable alternative relapse therapy concept, so here we see a very significant and noticeable improvement in progression-free rates of overall survival with, regarding teglitimab, we see this as a direct result of the very deep response quality in a substantially larger number of patients than we observed in the control arm. I think we have assessed the safety profile and found it to be quite manageable overall, but we need to pay close attention to infections and monitor the immunoglobulin levels very carefully. CRS should not be a reason to withhold initiating therapy here. We are also working on concepts for outpatient treatment in this context. And based on the comprehensive data we have gathered, we fully anticipate and expect an approval that will provide strong evidence to support the use of teclistamab starting from the second line of therapy and beyond. I think that today we are seeing more and more patients in this situation who, after 1 or 2 prior treatments, are already CD38 refractory. In first-line therapy, we have dara-lendex as the standard treatment, or dara-VRD or isa-VRD. In relapse and in the high-dose setting, we also quite frequently use CD38 antibodies in maintenance therapies, be it as part of approved therapies or in clinical trials. So this is going to become significantly more important to be able to offer something to patients in the second-line setting. We expect approval for teclistamab as monotherapy by the end of the year. Before that, approval for the combination with DARA will most likely be arriving in the month following the next one. I never grow weary of constantly pointing out infections as the main risk in the first 6 months. That is certainly something that can be life-threatening. Of course, we urgently need comparative data with CAR T-cell therapy because we already have an approved BCMA-targeted immunotherapy starting from the second line of treatment. And of course, many patients will ask, what should I do now, teclistamab or CAR T-cells? As soon as it is approved, that will naturally be a question that we will have to answer. And of course, questions about sequencing will arise anew, because then from a medical perspective, I will also have to answer what the order would be if we can offer both CAR T cells and bispecific antibodies. The data situation remains unclear on that. Current data come from the late relapse setting. Clearly use CAR T cells first, then the antibody. If this applies in early lines of therapy, we are currently not in a position to support with clear data. After this overview of some selected presentations, I am once again looking forward to Mr. Eisenbeisz's question.
Well, not so much questions. What really struck me, and I thought it was great, was this look into the toolbox, as you mentioned, especially in the field of immunotherapies like bispecific antibodies and CAR T-cell therapy. There is quite a lot happening, and it has shown what possibilities there really are for the future as well, are available to develop and adapt therapies accordingly. And I am curious to see how this will develop in the coming years. You yourself pointed out there are many things that will still take a long time before they are approved. And there are still a lot of questions that need to be answered. In this respect, however, I also think it is important that in the future we thoroughly inform patients about these possibilities. You mentioned shared decision-making before, and given the variety of options available in the future and some existing today, it is crucial informing patients early so they can be involved in decisions. This is personally very important to me. One more question. With the 2 CAR T-cell therapies, allogeneic and in vivo, I missed a reference to bridging therapy. Is that still necessary? Bridging therapy is used to cover the time between the collection of T cells and the reinfusion of the CAR T cells. Additionally, during this time, the myeloma burden is minimized as much as possible to make CAR T cell therapy even more effective to have. Is this omission deliberate, or is it simply no longer needed?
That's a really excellent question, because that was also a major learning curve we had to go through. We started out understanding bridging as simply a way to bridge time. The name suggests that as well. I keep advocating for us to rather call it induction therapy. That's actually how we see it nowadays. So far, I haven't been able to push this through, so the term bridging remains. But our goal is to reduce the tumor burden. With the current CAR T cells we have, we see that the duration of effect is improved by reducing the tumor burden and also the risk of side effects, especially neurological side effects. That's why it's absolutely right. Our current standard is that all patients receive bridging with the goal of achieving effective tumor reduction, not just a bit of cosmetic improvement in the lab, but truly a significant reduction in tumor burden. That is what we are aiming for. That's why this actually matches the goal of an induction treatment. And we are already witnessing the fact that the time until the cells are delivered is often much shorter than our intended duration of bridging therapy. Sometimes we already have the cells sitting in the tank for a bit longer and say, we'd rather continue one more cycle of bridging therapy to achieve a greater effect. The progress here is that we are providing more therapy and are no longer just focusing on bridging, but are keeping the therapeutic effect in mind. Now, if I have available cells, either the allogeneic CAR T cells or just the vector that needs to be injected, then of course this interim phase is no longer necessary at all. And now, of course, the question is whether the effect is so good with these two new concepts that we can do without bridging, and the effect is practically as good as bridging plus autologous CAR T cells. Of course, that would be the most desirable outcome. Or will we find over time that even with these off-the-shelf approaches, it is still advantageous in order to provide a pre-treatment? I think at the moment it's completely impossible to predict how that will turn out. That's why we actually need comparative studies that test CAR T against CAR T, so we can better understand this and really have a one-to-one comparison. So bridging plus autologous CAR T cells as we know it versus immediate off-the-shelf administration of vector or CAR T cells. I see the major difficulty that such studies become extremely expensive, and the companies naturally shy away from doing such things, especially when it's so hard to predict what the outcome will be. But I believe we can't avoid demanding such studies, and it will be extremely exciting to see how it turns out. However, one could certainly imagine that perhaps allogeneic CAR T cells might also expand more easily when there is less tumor burden. So in addition to the variables in the lab that I showed, where everything can be tweaked, of course, we also have many clinical variables, and we need to consider conducting studies that are as informative as possible. I advocate always for studies with as many as 3 or 4 arms, simply to include additional arms that help us learn. The companies always prefer to have 2 arms, ideally one product, and a control arm that is as conservative as possible so that approval can be obtained quickly. But for learning purposes, it's actually much better if we have multiple arms and can learn a great deal more in the end beyond just the question of approval.
Thank you very much, Professor Scheid. I hope that with these contributions, we can offer patients even more. They have provided a wealth of information. Personally, I'm curious to see what the outcome of all this is. Debuts at DGHO Congress in Vienna.
All right, thank you very much.